Let's go over the warm-up review. First question, where are the different types of collagen found in the body? So you might remember our mnemonic, a strong, slippery, stretchy BM for the 4 different types of collagen. Type 1 is the strong type, which is found in bones, tendons, skin, and the dentin of the teeth. Type 2 is your slippery type, found in cartilage, the vitreous body, and the nucleus pulposus. Type 3 is the stretchy type, found in blood vessels, in the uterus, fetal tissue, in the skin, and also granulation tissue. And then type 4 is BM for the basement membrane or the basal lamina. Then you can also remember SCAB for skin, cartilage, arteries, and basement membrane. That one's not as complete, but it's definitely shorter. All right, next. A 40-year-old man is brought to the ER following the sudden onset of a severe headache. He has a history of Ehlers-Danlos syndrome and hypertension. Examination of the CSF shows numerous red blood cells in the CSF. So what's the most likely cause of this man's headache? So this is a classic presentation for subarachnoid hemorrhage due to a ruptured berry aneurysm. Remember that the vascular type of Ehlers-Danlos syndrome is associated with berry aneurysms. The last one, how does the presentation of a dominant parietal lobe lesion differ from the presentation of a non-dominant parietal lobe lesion? The non-dominant parietal lobe is typically the right parietal lobe. The lesion there is going to cause hemispatial neglect, where the patient ignores or neglects the contralateral side of the world. And then a lesion in the dominant parietal lobe, which is typically the left parietal lobe, causes Gerstmann syndrome, agraphia, acalculia, finger agnosia, and left to right disorientation. Now let's go ahead and get started with the lecture.
Hello everyone and welcome to our Step 1 video on parasympathetic activation. Warning for this video, try to keep your mouth closed during the lecture. Not only will my Han Solo-esque rugged good looks cause your mouth to water, but the material itself will get you slobbering like a Pavlov dog in a bell factory. Don't worry, it'll make sense later. So today we're talking about the autonomic nervous system, and more specifically the pharmacology of parasympathetic activation. Now, in order to understand this, we have to take a brief step back and go over a little bit of the autonomic nervous system itself. Now, the autonomic nervous system is the part of the peripheral nervous system that helps to regulate many of our bodily functions, and luckily for us, it does this automatically. Now, where our somatic nerves are under voluntary control to flex our skeletal muscles, the autonomic nervous system is unconscious. Now, there are 2 opposing or maybe balancing forces in the autonomic nervous system. These are the sympathetic and the parasympathetic nervous systems. Now, you'll often hear the sympathetic nervous system associated with activities like fight or flight, and the parasympathetic nervous system associated with activities related to rest and digest. Now, we're going to concentrate on the parasympathetic nervous system really for the next 2 lectures. So where in the body is the parasympathetic nervous system? Well, let's think back to our cranial nerves. Cranial nerves 3, 7, 9, and 10 all carry parasympathetic nerve fibers. We also see parasympathetic nerve fibers come out of the 2nd and 3rd sacral spinal nerves as well. But having said that, about 75% of all parasympathetic nerve fibers are in the vagus nerve, so cranial nerve 10. Therefore, when we think about the parasympathetic nervous system, we will often be talking about the vagus nerve and its eventual innervations of a whole bunch of organs, like the heart, the lungs, the esophagus, the stomach, the small intestine, the proximal half of the colon, the liver, the gallbladder, the pancreas, the kidneys, and the upper portions of the ureters. Now, sometimes you'll just hear this referred to as vagal stimulation. Now, the autonomic nervous system sends out its messages to the organs by way of 2 different nerve fibers and a ganglion. So the first nerve fiber is called the preganglionic nerve, and it transmits its message to the ganglion, and I think of the ganglion as kind of like a relay station. Now, the message is then propagated to the second nerve fiber called the postganglionic nerve, and it ends at the effector organ. Now, the parasympathetic nervous system uses very long preganglionic nerves, and the postganglionic fibers are really pretty short, with the ganglia close to or even within the organ that it's innervating. Now, this is in contrast to the sympathetic nerves, which have relatively short preganglionic fibers and very, very long postganglionic fibers. So why is that important? Well, having these very long preganglionic fibers in the parasympathetic nervous system and very short postganglionic axons, it's really going to allow that parasympathetic nervous system to be more selective than the sympathetic nervous system. If you stimulate the sympathetic nervous system, you're kind of basically stimulating the whole system. It's very imprecise. In the parasympathetic nervous system, one postganglionic nerve is innervating one organ. Therefore, you can get a much more localized and precise stimulation. Now, the primary neurotransmitter of the parasympathetic nervous system is acetylcholine. The preganglionic neuron will secrete acetylcholine to stimulate nicotinic receptors at the ganglion. Now, the ganglion will then secrete acetylcholine again, which will stimulate muscarinic receptors on the effector organs. And this is important to know because many drugs exert what is referred to as muscarinic or anti-muscarinic effects. So now I want to briefly go over the difference between a nicotinic and a muscarinic receptor. These are the receptors that we'll see on the effector organs. Now, nicotinic receptors are ligand-gated sodium-potassium channels. Remember that we find these on our ganglia in the autonomic nervous system, but also be aware that the somatic nervous system uses nicotinic receptors at the neuromuscular junction as well. Now, muscarinic receptors are G-protein coupled receptors. They act through second messengers. Now, there are 5 subtypes, and they're named M1 through M5. Now, it's been said that the parasympathetic nervous system is associated with rest and digestion, but that's just a little too simplistic. Let's go through this by system. How does parasympathetic activation affect each organ? So what about the GI tract? Well, it's going to increase muscle motility and tone, so you're going to get more digestion, more transit through the intestines. What about the bladder? Well, you're going to get contraction of the wall, you're going to have relaxation of the sphincter. In the eye, you're going to get meiosis, and meiosis is constriction of the pupil. You're also going to get contraction of the ciliary muscles. That's going to lead to accommodation. In the lung, you're going to see smooth muscle contraction, so some bronchospasm. In the heart, you're going to get decreased heart rate and decreased contractility. In the lacrimal glands, you're going to get a stimulation of tear production. In the salivary glands, you're going to have watery secretion increased. In the penis, you're going to have an erection. In the clitoris, you're going to have an engorgement. Now, one way to remember excess cholinergic activation is with a mnemonic, dumbbells. This has been used for years. So DUMBBELSS. So it's not exactly spelled correctly, but it gets the point through. So let's go back to our list of parasympathetic activation, and now let's see what you get with too much stimulation. So you get diarrhea, you get urination, you get meiosis, you get bronchospasm, you get bradycardia, you get excitation of skeletal muscle and CNS. Now don't worry, we'll come back to that later. It doesn't fit our usual trend here. Lacrimation, salivation, and sweating, and we'll come back to that one as well. Now, one way I like to remember this is that everything becomes leaky. Extra fluid is going everywhere. Now, you'll notice that some blank areas in our parasympathetic list. Now, don't get confused. Cholinergic excess is not exactly the same thing as excess parasympathetic activation. A little confusing there, but we'll explain this. Cholinergic excess is another way of saying too much acetylcholine. So let me explain what I mean. Now, we just went through the parasympathetic actions, and I don't remember seeing anything about sweating or excitation of muscles. In fact, we should probably see relaxation of muscles in general with parasympathetic activation. So how do we get an excitation of skeletal muscle with too much acetylcholine? Well, what stimulates nicotinic receptors on skeletal muscle? Well, it's acetylcholine. So that's why you see muscle contractions or twitching with this organophosphate poisoning. Now, what about sweating? That one's a little bit more complicated. Sweating is controlled by the sympathetic nervous system, but it uses muscarinic receptors to stimulate that sweating. So remember that most of the time, the sympathetic nervous system likes to use alpha and beta receptors, which then respond to things like norepinephrine. But the sweat glands are different. The sweat glands are innervated with the muscarinic receptors. And what stimulates muscarinic receptors? Acetylcholine. And what do we have too much of in organophosphate poisoning? Acetylcholine. So that's how we get that extra E and S in our mnemonic. They aren't parasympathetic per se, but they are still stimulated by acetylcholine, and that's what's going on in this disease state. Now, if you're really smart, then you may argue, Dr. Lewis, the sympathetic nervous system uses acetylcholine to stimulate the ganglion. And I would say you're right. And you can see things like hypertension and even tachycardia with organophosphate poisoning. But acetylcholine will stimulate both the ganglion and the receptor in the parasympathetic nervous system. Therefore, you get a greater parasympathetic effect. And traditionally, test makers focus on the excess parasympathetic stimulation with organophosphate poisoning. Let's determine how organophosphates increase cholinergic activity. Well, organophosphates act by inhibiting acetylcholinesterase. And acetylcholinesterase is found in the synaptic cleft, and its job is to break down acetylcholine. Now, if you look at a synaptic cleft, you'll see a bunch of acetylcholine hanging out, and it stimulates muscarinic receptors. Now, acetylcholinesterase is also present, and it's breaking down acetylcholine, and it's breaking it down into choline and acetate. Now, if we don't have acetylcholinesterase, then we get way too much acetylcholine, and we get way too much stimulation of muscarinic receptors. So one way to counteract this is to competitively bind muscarinic receptors, to effectively block them. Now, what medication actually does this? Well, this is the mechanism of action of atropine, which is the primary antidote of organophosphate poisoning, atropine. Now, another treatment option for organophosphate poisoning is something called pralidoxime. So what does it do? Well, pralidoxime works by reactivating inhibited acetylcholinesterase. In general, pralidoxime is not given alone, but in conjunction with atropine. The highest yield stuff is the parasympathetic effects like bronchospasm, increased digestion, bradycardia, watery saliva, and stuff like that. Everything's getting leaky. So now we're going to cover some more specific drug categories. Now, there are two types of cholinergic agonists. And there are direct agonists and there are indirect agonists. Now, recall how we saw the neuron release acetylcholine into the postsynaptic cleft and bind to the muscarinic receptor. Well, the direct agonists are going to mimic the effects of acetylcholine. It's going to do exactly what acetylcholine wants to do. It's going to bind directly to the muscarinic receptor. So here are some examples. So the first one, bethanechol. And bethanechol is used in patients who get a postoperative ileus or urinary retention. Next, we have carbachol. It's used for glaucoma by causing pupillary contraction and will decrease intraocular pressure. Pilocarpine is a potent stimulator of sweat, tears, and saliva. Now, I actually had to use this on a patient of mine who had parotid gland cancer, and after treatment he had almost no saliva. His mouth was incredibly dry. So the pilocarpine was used to improve his symptoms, and unfortunately later on his saliva came back. Next, we have methacholine. It's been used historically as a challenge test to diagnose asthma because it causes bronchospasm. So next we have the indirect cholinergic agonists. So how do they work? Well, again, let's go back to our synaptic cleft. Remember that in the cleft there was those acetylcholinesterases, and its job was to break down that excess acetylcholine. Now, the indirect cholinergic agonists will inactivate that acetylcholinesterase and thus increase the amount of acetylcholine in the cleft, which leads to more stimulation of the muscarinic receptors. This should sound very familiar. This is exactly what we saw with organophosphate poisoning, but instead of poisoning people, we're giving them these medications to do a positive thing. So let's go through these. Neostigmine, that's used in post-op and neurogenic ileus and urinary retention. Kind of like just bethanechol. It's also used in the treatment of myasthenia gravis, and we'll talk about myasthenia in more detail in just a minute. It's also used to reverse the effects of neuromuscular blocking agents that are used in anesthesia. Next, we have pyridostigmine, and pyridostigmine is used for myasthenia gravis for long-term treatment. Again, we'll cover this in a little bit more detail in a minute. Next, we have edrophonium. Edrophonium is used in the diagnosis of myasthenia gravis because it's very short-acting. You might actually hear this referred to as the Tinslin test, but that's just the branded name for edrophonium. You probably don't have to memorize that. Next, we have physostigmine. Physostigmine is used for anticholinergic or atropine overdose. Next, we have ecothiopate. That's used for glaucoma. Donepezil is an Alzheimer's disease medication. We'll cover that in more detail right now. All right, so let's talk about Alzheimer's disease. So patients with Alzheimer's disease have reduced cerebral production of something called choline acetyltransferase, and that leads to a decrease of acetylcholine synthesis and impaired cortical cholinergic functioning. Therefore, to help this apparent lack of acetylcholine, we started using medications that inhibit the acetylcholinesterase and therefore increase the levels of acetylcholine in the brain. Now, the three that are FDA approved for Alzheimer's disease is donepezil, galantamine, and rivastigmine. Now, there's actually a new mnemonic that a student gave us to be helpful for Alzheimer's drugs, and it's Grandma Doesn't Remember, and that's to help you remember galantamine, donepezil, and rivastigmine. Now, at best, these medications provide a modest reduction in the rate of loss of cognitive functioning in Alzheimer's patients. Now, another indication that a patient has Alzheimer's is when you see amyloid deposits in the gray matter of the brain, and these are called senile plaques, so a good diagnostic thing there. So now, finally, let's briefly talk about myasthenia gravis. So what is myasthenia gravis? Well, it's a disorder with fluctuating weakness in the limbs, the eyelids, the extraocular muscles, and potentially respiratory muscles. Now, it's caused by antibodies to the acetylcholine receptor. Now on tests, you'll often see a question that describes a patient with worsening ptosis and diplopia that worsens throughout the day. Now you can diagnose this with that Tinslon test, that edrophonium test, which we went over. Again, that's just the brand name for edrophonium. Now this test can be very dramatic. If you ever get a chance to see it, it's really, really cool. I saw a patient that was almost completely paralyzed who was given edrophonium, and in a matter of seconds she was moving and talking and was so thankful. It's one of those kind of treatments that looks like a miracle. However, a more specific test is testing for the autoantibodies against the acetylcholine receptor. It's not as cool as edrophonium, but if you get a question about which is a more specific test, then go with the autoantibody test. Now, what are some of the other things that you should know about myasthenia gravis? Well, it has some thymic associations. 50% is associated with thymic hyperplasia, 20% is associated with thymic atrophy, and 15% is associated with a thymic tumor, like a thymoma. Now, the most worrisome condition is a myasthenic crisis. And here we see rapid progressing weakness, especially in the respiratory muscles. Now, for treatment, we've already gone over the indirect cholinergic agonists like pyridostigmine and neostigmine. Remember that edrophonium is a very short-acting medication. It's only used for diagnosis, not for long-term treatment. Now, this is an autoimmune disorder, therefore you can use immunotherapy like corticosteroids, azathioprine, and cyclosporin. Now, interestingly, because there's some connection with the thymus, patients with generalized myasthenia gravis will have a thymectomy, and that can help symptoms as well. Now, the last thing you can do is plasmapheresis, which can be used to help filter out all those antibodies that are inhibiting the acetylcholine receptors. All right, so that's the end of the lecture part. It's time for the end of session quiz. Try to answer those questions on your own, and then we'll go through the answers together. First question, how does parasympathetic nervous system affect the following body structures? So we went through this once, let's go through it again. The heart, you're going to get decreased heart rate, maybe a small decrease in contractility. In the eye, you're going to see meiosis, you're going to see contraction of the ciliary muscle. In the salivary gland, you're going to get increased saliva production and secretion. In the lung, for that bronchiolar smooth muscle, you're going to get contraction. For the bladder, you're going to get contraction of the bladder wall and relaxation of the sphincter. And the male GU, you're going to get an erection. And then on the GI tract, you're going to have contraction of the intestinal wall, relaxation of the sphincter, overall increase in transit. Next, what drug regenerates acetylcholinesterases after organophosphate poisoning? Remember, the drug there is going to be pralidoxine. Next, what is the antidote for organophosphate poisoning? Well, the antidote is actually atropine. Remember, we just talked about pralidoxine that can be used to help regenerate that acetylcholinesterase activity in the synaptic cleft, but the actual antidote is atropine. Next, which anticholinesterases are used in the treatment of Alzheimer's disease? So remember, it's going to be donepezil, galantamine, and rivastigmine. All right, and then finally we have just a couple rapid fire facts. Amyloid deposits in gray matter of the brain, that's going to be those senile plaques that we see in Alzheimer's disease. And then the drooling farmer, always think of organophosphate poisoning. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.